Assalamu alaikum. I am Dr. Mahbubur Rahman Polash, Assistant Professor, Department of Pharmacology at Bashundhara Ad-din Medical College. Welcome everyone in our today's session. Today we will discuss about drug used in bronchial asthma. We know diseases like asthma and COPD are very common in winter season, so we should have a fair knowledge about the management of asthma and COPD. Let's go start. What is asthma? Asthma, a chronic inflammatory condition of the airways characterized by cough, wheeze, chest tightness and shortness of breath. Here is a picture that shows patient with cough and wheeze. Triggering factor includes inflammatory factor, irritants and others. Inflammatory factor includes respiratory infections, work and allergens. Irritant factors include exercise, cold weather or cold air, stressful condition and emotion, strong odors and temperature change that are responsible for irritant factor, and others include tobacco, gastric reflux, pollutants, food additives and some medications. Cardinal pathophysiology of bronchial asthma. Cardinal pathophysiology includes airway inflammation and bronchial hyperactivity. Clinically, two types of asthma are identified: extrinsic asthma and intrinsic asthma. Extrinsic asthma starts at an early age, occurs in episodes. The patient has a family history of allergies, and in intrinsic asthma it starts in the middle age and assumes chronic from there is no family history of allergies. Approaches to treatment: prevention of exposure to allergens, reduction of bronchial inflammation and hyperreactivity, and dilatation of narrowed bronchi. There is a picture that shows the airway of normal patient and an airway of asthmatic patient. In normal airway there is no muscle tightening, but in case of asthmatic airway there is muscle tightening present. This is a common difference. Now come to the drugs. Bronchodilators. Bronchodilators, we can also say it asthma preventer and asthma reliever, and anti-inflammatory agent that we can say asthma preventer. Bronchodilators are beta 2 agonist drug. Short acting are salbutamol and terbutaline, and long acting are salmeterol and formoterol. Methyl-xanthine drugs include theophylline, aminophylline, doxophylline, and anticholinergic drugs are ipratropium bromide and tiotropium bromide. Anti-inflammatory agents, we also called them asthma preventer. Number 1, corticosteroid, two types, systemic and inhalational. Systemics are hydrocortisone and prednisolone, and in inhalational route we can give beclomethasone, fluticasone and triamcinolone, also budesonide. Leukotriene inhibitors are montelukast, and mast cell stabilizers include sodium chromoglycate, nitochromyl sodium and ketotifen. Now come to the mechanism of selective beta 2 agonist drug. They stimulates beta 2 receptor in the bronchus, active adenyl cyclase enzyme, increase CMP in smooth muscles. As a result, bronchodilation occurs. It also stabilizes mast cell, no histamine release and no bronchoconstriction occurs. Salbutamol, route of administration oral and inhalational. Selective action and duration of action 4 to 6 hours. Indications are bronchial asthma and chronic obstructive pulmonary disease. Adverse effect: muscle tremors, palpitation, tachycardia, anxiety and hypokalemia. Methyl-xanthine drugs, it includes theophylline, doxophylline, and mechanisms are they inhibit phosphodiesterase enzyme, increase CAMP level, as a result bronchodilation occurs. It also block adenosine receptor and produce bronchodilation. Route of administration, it gives in oral and parenteral route. Indications are acute severe asthma or status asthmaticus, chronic asthma and chronic obstructive pulmonary disease or COPD. Adverse effects are insidious palpitation and cardiac arrhythmia, GIT, nausea and diarrhea, and CNS, headache, nervousness, anxiety, insomnia and convulsion. Corticosteroids. Role of steroids in asthma as anti-inflammatory role, it inhibits synthesis of inflammatory mediator like cytokine, prostaglandin and leukotrienes, reduce bronchial hyperactivity and reduce microvascular leakage, mucosal edema and congestion. In this figure, from cell membrane phospholipid through phospholipase A2 enzyme, arachidonic acids it is a mediator from cell membrane phospholipid, and from arachidonic acid we through cyclooxygenase pathway prostaglandin, thromboxane and prostacyclins are found, and through lipoxygenase pathway we get leukotrienes. We know prostaglandin, thromboxane and prostacyclin, they are inflammatory mediator and that works in inflammation, pain, fever, and it has also vasodilatory, and prostaglandin has also vasodilatory properties. So if we give steroid, then no phospholipase A2 synthesis and no inflammation, as a result no asthma. Anti-allergic role, inhibits allergen induced influx of eosinophilia into lungs. Permissive role, increased sensitivity of beta 2 receptor to endogenous catecholamines to produce bronchodilatations. Adverse effect, inhalated steroids, oropharyngeal candidiasis or oral thrush that is treated with antifungal agent, and hoarseness of voice and throat irritations. These are the common adverse effects. And prevention, we can give advice to the patient to gargle after using oral steroid. Adverse effect of systemic steroids are diabetes mellitus, hypertension, peptic ulcer disease, psychosis and adrenal insufficiency. Now come to the mast cell stabilizer. Mechanism of actions are prevents degranulation of mast cell in lungs, decrease release of histamine, platelet activating factor and leukotriene C4 receptor. Adverse effects are nausea and vomiting, bitter taste in mouth and cough, and it is used in prophylaxis of asthma. Leukotriene receptor antagonists include zafirlukast and montelukast. Mechanism of action of montelukast are montelukast that blocks leukotriene 4 LT4 receptor, no action of leukotriene, and it decrease airway inflammation and decrease bronchial hyperactivity. Advantage can be given to children 1 year of age and older, available in chewable tablet and granule formation. And adverse effects are eosinophilia, vasculitis, and drug interactions may interact with warfarin and decrease prothrombin time. Now, acute severe asthma or status asthmaticus, this is a life-threatening emergency requiring rapid aggressive management. It is characterized by wheeze, breathlessness to such extent that the patient cannot complete sentences in one breath, tachycardia, central cyanosis and sometimes pulsus paradoxus. Now come to the treatment of severe acute bronchial asthma. Number 1, propped up position. Number 2, oxygen. Give high flow oxygen 4 to 6 liter per minute. Maintain oxygen saturation above 92%. And number 3, high dose of inhalated bronchodilators are given like salbutamol by nebulizer in a dose of 2.5 to 5 milligram over about 3 to 5 minutes. Repeat if necessary. And ipratropium bromide 0.5 milligram may be added to the nebulized beta 2 agonist drug. Number 4, systemic corticosteroid hydrocortisone 200 milligram IV 4 to 6 hourly, then switch to oral prednisolone 30 to 60 milligram. Number 5, intravenous aminophylline. If the condition is very severe or respiratory failure is present, then it is given. Intravenous fluid to correct dehydration, and broad spectrum antibiotic IV or oral if patient has pulmonary infection. Monitoring of treatment, peak expiratory flow should be recorded every 15 to 30 minutes and then every 4 to 6 hours, and pulse oximetry should ensure that saturation of oxygen is greater than 92%. Now come to the difference between salbutamol and theophylline. Number 1, mechanism. Salbutamol acts through selective stimulation of beta 2 receptor in bronchial tree, and theophylline inhibits phosphodiesterase enzyme. Routes, salbutamol is given in inhalated and oral route, but theophylline given in IV and oral route. Duration, relatively longer in salbutamol but shorter in case of theophylline. In acute asthma, nebulized or inhalated form salbutamol is given, but in theophylline given in IV route. And adverse effect of salbutamol are tremor, tachycardia and hypotension, but in case of theophylline, adverse effect are arrhythmia, palpitation and insomnia. So, this is all about today, and thank you all for patient hearing. Allah Hafiz.